Next, now I would like to invite Dr. K. Manikandan for the talk on why is neurosonogram must in a monochorionic pregnancy. He is a lead consultant for the fetal therapy at the fetal clinic Pondicherry and also attached to the KMCH Coimbatore and KFM Pune. His special interest in preeclampsia prevention and evidence-based teaching. Thank you. Welcome.
Good evening. Thank you very much for the opportunity. Before we start, how many of you have encountered when you give a diagnosis of monochorionic pregnancy and then they don't come back because the obstetrician terminated the pregnancy? It's sad, but that was also because of our inability to give them a clear answer and some solutions. The topic today is why is neurosonogram a must in monochorionic twins. We'll see some cases, and based on these cases and the understanding, we'll come to a conclusion on that. So this is a case at 20 weeks referred as TTTS stage 1, shows primary natural conception. There was monochorionic pregnancy, and in the larger sac, the polyhydramnios was not really that much, but on the smaller sac, there was no oligohydramnios to say. So here it's only a discordance, but the true diagnosis, as you can see here, is a difference in the growth. So this would be what? A selective FGR. And to type it, we should go to the placental end of the cord of the small one. And when you do that, this is what we get. So it is a type 3 selective FGR. Okay. Now, type 3 selective FGR, we know, we counsel based on the paper by Gratakos, and it is the ugly type where, you know, things can go well or seem to go well, but you may end up with some neurological outcome, bad outcome for even the larger twin. So intensive monitoring was proposed, and we said we will intervene if the smaller twin showed any deterioration. It didn't show, and she reached about 31 plus 4 by the time which the intermittent ADF became fixed REDF. So she delivered by 32 weeks by elective LSCS. The smaller twin was 1110, and it's okay. So they stayed for NICU for some time, and I called them back for early neonatal neurosonography, and it was all okay. There was no finding in both fetuses. The neonatal energy was okay. So I called them back after 3 weeks. And you can see in twin B, there is new appearance of ACPC, that is subependymal pseudocyst. But the babies were looking okay, and the neonatologist did not have any concern. So was sent back and were asked to get a follow-up after some time. Currently, the babies are about 1 year and 6 months and are doing well, but I don't have any MRI report on this. All right. Now, let's go to second case who was referred because of suspected polyhydramnias. And this is very obvious, isn't it? In SAC1, there is 13 Leica, 13 centimeter, and SAC2, no Leica, stuck baby. And you have AEDF in both umbilical arteries. So what stage of TTTS is this? Stage 3, critical Doppler. And the MCA did not show, you know, the TAPS criteria. Then before we went on to discuss what modality of intervention should we do, we did a neurosonogram for the recipient. And this is what we see. Can you see that the whole of parenchyma is too bright, too dark, too small, too big? All are not good in neurosonography. And also you can see that there is a really bright patch just around the periventricular area. And you can see here that the enhanced echogenicity around the ventricular area and in the basal ganglia region. This is for comparison. Here, this is a hemorrhage, and all this represents edema. So this is a grossly, badly affected brain. The one on the right side is for comparison. So a small clip. There is something else also seen in this clip from apart from what I had mentioned. Anybody can tell that? What about on the surface of the cortex? Yeah, too bright, isn't it? So maybe blood, maybe hemorrhagic destruction. All right, so now it is TTTS stage 3. There is cerebral edema, hemorrhagic stroke, parenchymal abnormality. So she is not a candidate for fetoscopic laser ablation. So we had advised, in fact, we are not willing for anything because the other one was also very small and showing ADF. We offered bipolar, she didn't take it, and then she aborted spontaneously after some time. And within a week, the next came case. So this was at 24 weeks, 6 days. Again, suspect, but this time the referral was TTTS itself. There was TTTS, and there was poly-oligo sequence. The donor was stuck, but the recipient was already in high drops. And you can see that the recipient heart is quite bad. There is functional RVOTO with regurgitation, bad DV. The donor was okay from Doppler point of view. And because we had already seen that, we waited for the recipient to come to a good position and we did a TV neurosonography. And this is what we see. Almost the same picture. There is cerebral edema. Everywhere it's white. The lamination you cannot make out. And you can see big chunks of hemorrhagic area in the basal ganglia region and in the temporal lobe. So this is slightly in the frontal region. Yeah, grade 4. Multiplanar imaging confirming the same. This is a clip. You can also see the same cortical echogenicity even in this fetus. All right. So again, it's TTTS, this time stage 4 with cardiac and badly hit brain. So we offered bipolar cord coagulation for the recipient, which was done successfully, only to have her expelled in about a week later, and she lost both. We'll go to the next case where it was referred at 29 weeks for a monochorionic twins with a single fetal demise. So we know that's not good for the other twin. So immediately after confirming the single fetal demise, we go and check. There was, footprints of a pre-existing TTTS that had led to the demise of one twin, the donor. So the recipient now shows MCA PSV of 73. Good, bad? Bad. The recipient showing MCA of 73 means it has exsanguinated so much now. So it is in anemia. So that's not going to be good. So what we do a neurosonography. But when you have anemia, that means the demise was long ago or recent. So do you see something in the brain? Because of the exsanguination, you may not see. You might have had before that also. But unfortunately or fortunately, we didn't see anything in the brain at this stage. We sent her back with caution, saying that we might see something coming up later. So we said we'll see you back in 1 week's time because there is anemia and there was TTTS that had led to the demise of the first twin. After 1 week, we didn't get her. When we called up, she told she went into labor, delivered, and the recipient died 14 hours of life. All right, let's go to the next case. This is a 19-weeker, primary natural conception. This was quite early in my intervention career. TTTS, anterior placenta, and look at the donor. The donor is stuck between the recipient cord and the donor cord insertion. So it's like lying on the vascular equator if you map. So I said it's not possible to do a fetoscopic laser. I will do a radiofrequency ablation. So we went ahead and did a radiofrequency ablation. These are the Dopplers. So TTTS stage 3 because the recipient was showing AEDF. So after discussion, radio frequency ablation was done and the recipient was reduced. And immediately the next day, this is what was happening to the donor. The MCA PSV was 60 and there is a little bit of pericardial effusion. So the donor has exsanguinated, the RFA was not good. It didn't completely coagulate possibly. So we did an emergency intrauterine transfusion the same day, but we warned her that it doesn't look good. The transfusion can save the baby, but we cannot say about the neurological outcome. So when there is a single demise and you pick up in the stage of anemia, you correct the anemia, you can save the baby from demise, but you can't save the baby from neurological damage. As in this case, you can see there is bilateral hemorrhage in the basal ganglia region and also in the periventricular region. So we explained that the prognosis was poor, even though the donor is already showing recovery from TTTS. Liquor is coming, bladder is coming back, but the brain has been fried. So with some sadness, we had to terminate the pregnancy. And for 6 months, she was a very lovely lady. Both of us were communicating and we were, consoling each other to get out of the post-traumatic stress disorder. Yeah. So, and she called up recently and said she had the next baby and delivered from Delhi actually. So this is the next case, 20 weeks, referred for single fetal demise in a monochorionic twins. So the surviving twin was all right and the demise twin was showing an FL of 17 weeks. But when we look at the brain, things were okay initially. The neurosonography was unremarkable. You can see here, everything was okay. The echogenicity of the parenchyma. So we look specifically for hemorrhagic and ischemic lesions in a case of monochorionic NSG. In addition to structural, but that's not increased. All right. So go to the MCA and the MCA is 38.2. It's like 1.5. If you repeat it, it keeps coming as 1.5. So we said it is indicative of mild to moderate, but the threshold to transfusion is not there. Since there is a demise and there is mild anemia, we'll keep you under NSG monitoring. You might have to face a neurological problem later on. If we find it, then we'll tell you. So she came very religiously. She came every 2 weeks. We kept monitoring. Nothing showed up to 34 and then 36 weeks also. The brain was growing well. So nothing happened. So she delivered. All neurosonography images were normal throughout the gestation. All right. So she went on to deliver vaginally at term, 2,600 grams. And that was recently, now 3 months over. She has yet to report for a formal assessment. So sometimes we will be able to see antenatally, but some of them escape also. All right. So having seen these very manifestations in different situations, what is that we are trying to do when we see in a monochorionic pregnancy, especially neurosonography? So before that, how many of you do a routine echocardiography in a monochorionic twins? All of you. And neurosonography? Few of you. Okay. So after this, all because of the conference itself. No? Yeah. So we need to also know what we are looking for in a monochorionic twin neurosonography. We are specifically asking the question, is there a hemorrhagic lesion or is there a ischemic lesion? So the morning class about the stroke, we need to remember and we need to look for that. In order to also reinforce your own concepts, we need to understand that these lesions in the monochorionic pregnancies are primarily because of the angioarchitecture at the placenta. There are only two concepts we need to know. One is territorial discordance. So if you look at the monochorionic placenta, it is almost always unequally divided. So one fetus gets a smaller portion, the other fetus gets a larger portion. The degree of inequality may differ. And because the cord insertions sort of provide information on the inequality, it's a good idea to always map the cord insertion onto the placenta and record it. The EFW discordance will tell us how much placental share or territorial discordance is happening. It's universal. Now, because of this discordance in weight, the blood pressure may be different between the two babies, and it can change during the course of pregnancy also. Now, in addition to territorial discordance, you should also know that there will be inter-twin anastomosis. So, on the surface of the placenta, when we do dye injection studies, we will see that one baby, its own territory, it will have the cotyledon. So, supplied by a artery and then drained by a vein. And the other baby similarly will have its own cotyledon. So, these are unshared cotyledons. But if you see even more closely, you will see that artery from one baby comes, dips into the placenta, but the draining vein goes to the opposite side of the opposite baby's territory. So this is a shared cotyledon. And along the placenta, if you see class closely, you will see that some of the arteries simply keep on going to the other side and continue going to the opposite fetus's cord. Now, they may give branches, but they do not change their caliber and go, and these are the arterio-arterial anastomosis. And in fact, when you do the fetoscopy, you can pick up all these things even more dramatically instead of looking at the pathological specimen. So here there is an artery coming from the top, and then it gives, and then the vein drainage is going to the bottom of the screen. Now, intertwin anastomosis, they are universal. The largest pathological study has shown that almost all 99% of placentas will show intertwin anastomosis. We can classify them as two categories: the superficial one, which is the arterio-arterial anastomosis, and the deep ones, which is the arteriovenous anastomosis. Arteriovenous anastomosis can be from fetus A to fetus B, and the blood flow will be from the artery to the vein. So they are unidirectional. Whereas arterioarterial anastomosis, the blood flow can be bidirectional, and this is explained by the concept called hemodynamic equator. And this hemodynamic equator is the point where the blood flow from both babies come and meet, and then this can be dynamic. This can change based on the two babies' relative blood pressure. So it can swing to this side and to the other side. Hemodynamic equator, you can see the, if you have good ultrasound machines, you go to the cord insertion site, switch on the color, adjust the color setting little bit, and you can keep seeing that the color changes, the flow changes on the prominent AA vessels. If they are that prominent, you can pick up that. We tried doing this with the low flow and the micro flow, but it's not really coming up well. So it needs a little bit of lumen caliber. Now, arterioarterial anastomosis are not universal, unlike AV anastomosis. When monochorionic twins are uncomplicated, you see a lot of AA. So that means they are protective. This is the common understanding. In TTTS, in the usual forms, that is stage 1, 2, 3, you may have about 25% of them showing AA anastomosis. The hydropic ones that quickly go in for recipient hydrops, it's actually less. So that sort of explains the pathophysiology. In SFGR, especially in type 3, arterioarterial anastomosis are quite common, and that contributes to the umbilical flow that is pathognomonic of SFGR type 3. So what happens when there is an AA anastomosis? You have the equator, that is the place where the waveforms meet. It can be in the center, then it is non-contributory. There is no blood going to either baby. But during episodes of hypotension or hypoxia, it can go to one baby, in which case it will be an AV anastomosis from the lower baby to the upper in this example, or it can go to the opposite side, in which case it is the opposite. It behaves like an AV anastomosis in the opposite direction. So in 2006, the group from Netherlands published what all lesions that we can pick up antenatally or were prevalent antenatally in monochorionic twins, and almost all hemorrhagic ischemic regions have been described. They have been described in twins with TTTS in greater frequency, but they are also present in monochorionic twins without TTTS also. So you have IVH, you have periventricular leukomalacia, ventriculostriate vasculopathy, SCPC, ventriculomegaly, porencephaly, and severe cerebral lesions like the one we saw in our cases. So there is a recent meta-analysis in 2022, which summarizes why we should do neurosonography in monochorionic twins. Simply the rates of impaired neuro outcome and cerebral palsy in monochorionic twins is quite high compared to dichorionic and very high compared to singleton also. So based on all these things, the current ISUOC guidelines for targeted neurosonography indication includes monochorionic twins as one of the indications. So to summarize, monochorionic twins have an increased risk of abnormal neuro outcomes, so especially ischemic and hemorrhagic lesions. And the angioarchitecture of the placenta seems to determine the risk. If you have fewer AA anastomosis, you are at greater risk. If you have IUGR, you have greater risk, but the highest risk is with TTTS. And what we should look for is ischemic and hemorrhagic lesions. We know we have to do the neurosonography in monochorionic twins, but the question is how frequently? Okay, so I leave you with that answer. Thank you very much.
Thank you so much, Dr. Manikandan, for a wonderful talk. Without further delay, Dr. Michael Brusselot is waiting online to join us from Tel Aviv, and he'll shed some light on third trimester neurosonogram. It's never too late.
Hello, everyone. Do you hear me? Do you see me?
Yeah, we can hear you. Please go ahead, sir.
Okay. I have a mission impossible today in 20 minutes to convince you that the screening in the third trimester no less important than the first and second. The whole world strives for early diagnosis, but it's impossible to see what has not yet happened. I will try to do it. I'd like to start from the end. This is a case ongoing now. This is twins pregnancy, first spontaneous pregnancy. I did the first examination in 14, 15 weeks, was normal, and the 22, 23 was normal too. Now in 30 weeks, and this is a twins with the normal CMA, torch negative, and we can see different brain findings. This is fetus A, fetus B by transabdominal examination. You can see coronary plane. Maybe you have any questions on the structure and the contour of the brain. We can see here a cystic finding, unilateral, and normal corpus callosum. I can't say nothing about echogenicity because it's a transabdominal approach. To compare, it's 28 weeks of the pregnancy, another baby with a frontal sulcation. This is twin B. You can see here anterior part, anterior frontal sulcation, olfactories. In my opinion, more prominent frontal sulcus, and one more finding in the vermis, cystic finding in the vermis. Okay, there's a case for the questions. Now we will go ahead to my presentation. Okay. Reason for, examination of the fetuses in the third trimester, in my opinion, we have 4 groups. One is infection, bleeding, malformation of cortical development, and tumors. Let's start from infections. We know 3 main infections during pregnancy. The first one is cytomegalovirus, toxoplasmosis, and parvovirus. This is a case of the cytomegalovirus. We can see here high echogenicity periventricular, lot of fluids in the extraaxial plane, thalamic echogenicity, and intraventricular synechia. Next case, we can see here cystic malformation in the head of the caudate. intraventricular synechia, thalamic calcifications, and all of these signs we have pre-diagnoses: CMV, CMV, and CMV. One more in 28. Cystic malformations or distractions, calcifications, and periventricular hyperechogenicity. The next one is toxoplasmosis. Toxoplasmosis infection with the protozoan parasite Toxoplasma gondii has a worldwide distribution. This obligate intracellular parasite can infect humans as well as warm-blooded animals, including mammals and birds. Placental barrier is more efficient in the beginning of gestation. Less than 10% of cases during first trimester and more than 17% in the third trimester. This is a case in 24.5 weeks of the pregnancy, case of toxoplasmosis, ventriculomegaly, parenchymal nodules nodules in the parenchyma, periventricular echogenicity. One more, non-explained recurrent, many findings in the parenchyma. Ventriculomegaly, parenchymal nodular focuses, and ascites. Parvovirus, human parvovirus infection occur worldwide. Approximately 15 of pregnancy women are non-immune. Vertical transmission is common following maternal infection in pregnancy. This is a case in 26 weeks. You can see here a lot of fluids in the abdominal around the bowel. Heart insufficiency, and in the brain findings, you can see here high echogenicity around the ventricles, frontal lobe, and cystic destruction of the brain. The next group is the bleeding and the vascular accident. First of all, we can see blood supply of the brain by internal carotid artery, basal artery, pericallosal artery as part of the cerebral artery, and venous drainage, superior sagittal sinus, striate, transverse, and area of turcular heterophyly. Circle of the Willis, anterior cerebral artery, anterior communicated artery, middle cerebral, posterior communicated, and posterior cerebral artery, normal circle of Willis, and one more important part of the vessels in the brain, the medullary veins. So the first case of normal development of the corpus callosum in 22-23 weeks. The patient referred to our center because suspicion of abnormal midline by my colleague in 38 weeks. On the axial plane, transabdominal, looking normal, but by transvaginal approach, we can see here just anterior part of the corpus callosum, the rostrum, genome, and anterior part of the body, without posterior part. You can see here a radial sulci coming close to the area of ventricles. So it's a case of destroyed corpus callosum, most probably by vascular accident during pregnancy after second anatomical screen in 22-23 weeks. You can see here curves of the corpus callosum, abnormal, and absent posterior part of the corpus callosum. Again, radial sulci. Now, I will show prenatal sinus thrombosis. This condition can involve any of the brain venous sinuses, but almost all the prenatal diagnosis cases occur at the confluence of the superior sagittal sinus with the transverse and straight sinus, the torcular heterophyly. This is an image of axial plane, posterior part of the brain, cerebellum, and a hyperechogenic area behind the cerebellum. By transvaginal approach, we can see in the sagittal plane falx, vermis, cisterna magna, and thrombus in torcular heterophyly. On the coronary plane, the same place, coronary plane and mid-sagittal plane. Intracranial hemorrhage is relatively common in preterm neonates. However, fetal intracranial hemorrhage rare, with the estimated incidence approximately 1 in 10,000 pregnancies. In most cases, bleeding occurs late in pregnancy after a normal second trimester examination. The diagnosis is usually incidental during performance of routine third trimester ultrasound. It may be intraventricular, subarachnoid, subdural, and cerebral. The major reason for bleeding is trauma, seizure, hypoxia, ITP, etc. This is a case of my colleague Rui Birnbaum. During routine monitoring in the iris department, the fetus was with tachycardia. In the ultrasound, you can see here signs of anemia, high flow in the middle cerebral artery, and hyperechogenic patch in the thalami. So we can see here bleeding in basal ganglia, extracerebral subdural hematoma. The fetal factors may be TTTS, fetal maternal transfusion, death of co-twin, fetal thrombophilia, cord entanglement, and etc. And this is a case of the bleeding subdural hematoma. The patient was referred in our center from another hospital, and you can see here area of the bleeding subdural hematoma. It's different situation with dural separation. On the right side, you can see here dural separation, absolutely benign situation, and the left side is subdural hematoma. Dural separation is relative common finding. You can see here in 17 in October, and 2 days later, it's 2 different cases. So it's relative common finding, absolutely benign. Now we'll speak about IVH, grading of IVH. Grade 1, bleeding confined to the subependymal area, 2, hemorrhage with clots without dilatation, 3, ventriculomegaly, and involvement parenchyma is grade 4. Outcome grade 1 and 2, comparable with the preterm neonates without ICH, and grade 4 with very bad prognosis. With 16% of severe neurologic sequences. This is a case of the grade 1 bleeding. You can see here high echogenicity close to the lateral ventricles, close to the wall of the lateral ventricles without dilatation. This is a case of the grade 2. source of the bleeding, hemorrhage and chorial plexus, with dilatation of the lateral ventricles. This is a case of the grade 4. You can see here destroyed of the parenchyma of one of hemisphere. One more. Severe bleeding with damage of the parenchyma. I like show you 4 cases of the bleeding with different follow-up and different prognosis. The first case, patient referred to our hospital and our department because suspicion to ventriculomegaly. As you can see here, lateral ventricle was normal posterior part, cerebellar part normal. Nothing information about any pathology by transabdominal examination. And by transvaginal examination, we can see normal corpus callosum, normal midline, normal posterior part, brainstem, vermis, cisterna magna. But something wrong was here in the area of the frontal lobe. You can see here high echogenicity. On the right side, multiplanar reconstruction, and on the left side, you can see here live, something wrong with echogenicity in the frontal lobe. So you can see here a source of the bleeding in the area of caudothalamic groove. The size of the bleeding was relatively little, but on the coronary plane, you can see here high echogenicity close to the anterior horn of the lateral ventricle. And in this scheme, you can see a scheme of medullary veins, spread of medullary veins, deep medullary veins. And in the ultrasound, it was absolutely identical picture of spread of medullary veins. Here and here. 2 weeks later, you can see here cystic findings in the brain, in the parenchyma, and the same findings on the MR. So it was a case with a relative bad prognosis because damage of the parenchyma. The second case, bleeding in 24 weeks with involvement of the parenchyma, ventriculomegaly, blood clots, and the source of the bleeding. Was destroyed of parenchyma. Case number 3, parenchymal bleeding without parenchymal damage, ventriculomegaly.
Sorry for interruption, sir. We have 2 minutes only.
2 minutes, okay.
Yeah, thank you.
Okay, so hemorrhage, most often in the 3rd trimester, course and sequencing different follow-up necessary, a major clinical correlating cases with leukomalacian, spastic hemoparesis, and asymmetric quadriparesis. Next, large group malformation of cortical development, microcephaly, microcephaly, I not have a lot of time, but I want to show you two cases of macrocephaly, 33 weeks plus 3 standard deviation by Chernak head circumference. You can see here abnormal hypersulcation frontal lobe, huge corpus callosum, temporal lobe, and final diagnosis was a Noonan syndrome. And another one, macrocephaly plus 3 standard deviation with normal sulcation, normal corpus callosum. It was normal baby. If I have 1 minute, I will speak about heterotopia.
1 minute, sir.
What?
1 minute, sir.
What?
Yes, sir.
Okay. Heterotopia mirrors organization in the periventricular region fails to migrate. Type may be periventricular focal band heterotopia. This is the case of the periventricular heterotopia. You see here bumping on the lateral wall of the lateral ventricle. One important posterior heterotopia have significant higher incidence of associated hippocampal cerebral and brainstem anomalies. Diffuse heterotopia have associated agenesis of corpus callosum and megacisterna magna. Genetic etiology not assigned in most cases. I can continue. Okay.
We are
Reasons
running off short of time, so if it is possible to just conclude. We are
Okay.
running short of time, so can we please conclude if possible?
Conclusion. 22 weeks, it's only middle of the way. It's not enough. Malformation of the brain are not the most frequent, but the most terrible in their consequences. Thank you.
Thank you so much for a wonderful information, sir. Now we are moving on our next talk by Maria Sabina Saverino on the fetal and neonatal brain in metabolic disorders. She is joining from the Italy, and she is a pediatric neuroradiology consultant, Gasoline Children's Hospital, Genova, associate professor in neuroradiology and lecturer at the University of the Geneva. She is a special interest in rare neurological conditions, including malformations, metabolic and genetic disorders. Welcome, ma'am.
Good afternoon. First of all, I would like Good afternoon, ladies and gentlemen. First of all, I would like to thank the organizer for inviting me here. It's a pity not be with you in India, but I'm enjoying the meetings online and I really hope to be with you next time. So the topic of my presentation is fetal and neonatal brain metabolic disorders. Those are actually individually rare conditions, but altogether they represent a large group of disorders with up to 1/4 of cases presenting in the neonatal period and often detected by screening tests, and very ultra rare prenatal presentation. In the neonatal phase, early symptoms are frequently non-specific and they may mimic other more common neonatal diseases. But since some are treatable, it's very important to tune our diagnosis, improve our diagnosis in order to start the appropriate therapy as soon as possible. As you well know, in utero, there is sort of a detoxifier role for the placenta and the maternal metabolism that will actually reduce the manifestation of inborn errors of metabolism in the fetuses. But as soon as these little fetuses are born, this protective role subsides and they may manifest with symptoms. Sometimes, however, they can also have the fetal presentation. And as for other acquired fetal injuries, in this case, the timing of the insult is more important than its nature, which means that very early manifestation will actually end up with abortion, while later on, manifestation will manifest with malformations, or even later with injuries. Sometimes those patterns are intermingled and can overlap. If we have a look at the clinical presentations, usually the earliest is the onset, the more profound is the metabolic derangement. And we can further subdivide inborn errors of metabolism present in the neonatal phase depending on the timing of the presentations. And we can appreciate that fetal ones frequently overlap with those presenting in the very early days of life. But from a clinical point of view, whenever we have a neonatal inborn error of metabolism, we can have some clinical findings that can at least make us suspecting a condition, a metabolic condition. For instance, neonates can present with high lactate and hypotonia in the cases of mitochondrial disorders, or seizures and hypotonia in peroxisomal disorders, or cardiomyopathy, unexplained hypoglycemia, liver failure, or hyperammonemia. So if we pay much attention to this kind of clinical and features, we might have the suspicion of these disorders. And we can then add several other tools. So we can have the laboratory testings, screening programs, as I said before, imagings, of course, with MRI, and some neurophysiology that can help us. However, in the prenatal phase, we are left alone with some of amnestic information regarding the family history or gestational history, plus some imaging that is usually ultrasound and MRI, with very, very difficult detection in utero. Regarding the imaging findings, indeed, we are left with non-specific imaging signs, such as ascites, hydrops, fetalis, IUGR, echogenic kidneys, or stippling of the epiphysis. Sometimes we can find hyperechogenic colon, or dysostosis and bone abnormalities, and of course some cerebral anomalies, which will be the topic of my presentations. And the important concept is that all these findings can be more suspicious of a metabolic disease when they are associated and in the context of consanguineous parents or recurrency in the family. So let's start with some conditions and see which are the neuroradiological signs that can let us suspecting the metabolic condition. Zervaghetti syndrome is a peroxisomal biogenesis disorder due to mutation in the PIX gene, and it's very rare condition. In the neonatal form, neonates have a facial dysmorphism with severe hypotonia and seizures, and they have a plethora of symptoms, as you can see here: failure to try, hepatomegaly, coagulopathy. And on X-ray, we may see the calcific stipplings at the level of the rotula, the kidney, the knees, and the elbows. On MRI, we can have, in the neonatal presentation, diffuse frontoparietal cortical malformations that in this case is actually polymicrogyria, associated with some reduced white matter volume and signal alteration. In this case, you can also appreciate diffuse enlargement of the perivascular spaces. plus some corpus callosum dysgenesis and other multi-organ involvements. In this case, there was some multicystic kidney. But what about the fetal presentation? Well, we can also detect some of these abnormalities in utero, specifically the gyration anomalies with this, in this case, the poor opercularization, leading to the suspicion of polymicrogyria in the late phase of the disease, associated with some germinolithic cyst, and again, some additional features in the kidneys, here on ultrasound and fetal MRI, or as you can see here in the ultrasound Stipling's epiphysis. Of course, this gives me the opportunity to remind that cortical malformation have a very different presentation in utero, and we can frequently have to adapt our terminology and change the principles and nomenclature compared to the postnatal findings, as we heard yesterday in the beautiful lectures on cortical malformations. And also it's important to remind that fetal malformation of cortical development can be a sign of metabolic disorders, but we may remind that they can change in appearance. As you can see in these cases, we can have larger areas of abnormal cortical foldings in the later phases of gestations, or even the new appearance of abnormal sulci and abnormalities compared to pretty normal early MRI scanners. Let's move to glutaric aciduria type 1. In this organic aciduria, we have three main phenotypic patterns that may vary from asymptomatic cases to acute encephalopathic crisis and more insidious onset of motor delay and movement disorders with typical dystonia. This is a rather treatable condition with the L-carnitine, and actually on MRI we see the effect of the accumulation of intermediate breakdown products, indeed the glutaric acids, in the basal ganglia and white matter. And so this is the full blown up imaging phenotype in an adolescent with an enlargement of the CSF spaces here at the level of the temporal poles, plus the typical striatal necrosis here in the posterior portion of the putamen, plus the white matter involvement that can be very severe, and some subependymal nodules. But what about in utero presentation? Here again, we have a kind of a sign of malformation of cortical development with lack of opercularization of the Sylvian fissures and very small temporal lobe tip, as you can appreciate in this case of Dr. Regini. And the postnatal MRI actually confirmed all these features and also showed additional white matter signal alteration and some signs of basal ganglia involvement in a large head size neonate. And that's important to remind that in the early fetal life, the fetal head circumference can actually be normal or even smaller, and then sometimes the macrocephaly is only apparent later on along the course of the disease. Late fetal presentation can show even larger increase of pericerebral spaces with lack of opercularization again, and some germinolithic cysts that can, in this case were confirmed on postnatal MRI. As you can see here, this is another sign that can point to metabolic disorders. Germinolithic cysts have been also called subependymal pseudocysts or preventricular pseudocysts, and they are the result of the lysis of undifferentiated cells in the germinal matrix. They're quite a frequent finding in newborns, especially in preterms, and when they are isolated, they are usually a benign finding with spontaneous regression. However, if they are associated with other findings, they, even if they regress, they have a worse prognosis. And indeed, this may be found in the context of acquired lesions, so hemorrhages or infections, toxins, and of course also syndromic and genetic conditions, among which we have the inner error of metabolism. And it's important to remind that the location of this cyst should be below the roof of the lateral ventricles, as you can see in this scheme. And actually, some authors claim that when they have a posterior extension along the podothalamic notch and have a temporal or occipital location, or they are very long with a great axis of more than 9 millimeters and then the typical morphology, they are more frequently associated with an underlying condition, so gathering a worse prognosis. Let's move to another organic aciduria. This is an extremely rare phenotype. Again, it's a case that was brought by Andrea Righini. And you can see here that, again, we have signs of destruction with germinal matrix hemorrhage and cysts here, and some also ganglionic eminence cavitations. And here you can see the red arrows are pointing to the hemorrhage of the germinal matrix. So in some cases, it's slightly more difficult to differentiate the germinal matrix cysts from ganglionic eminence cavitation. And also it's important to remind that even though the latest one are actually signs of halted brain development. So it's not unlikely that may coexist in metabolic errors presenting in utero. So what about mitochondrial diseases? They can have a neonatal onset in up to 28% of cases. They have a diverse genetic etiology, even in this age group. And these patients usually present with prematurity, IUGR, hypotonia, or cardiomyopathy, seizure, or Lee syndrome. So they have complicated clinical onset with possibly elevated lactate levels and hyperharmonia. And unfortunately, in this phase, they have a very high rate of mortality. The images here of MRI shows the patterns in older kids that usually are variegate, and we have different types of involvement with some conditions, mitochondrial conditions that have a selective vulnerability for the gray matters with Lee-like patterns, or thalamic involvement, as you can see here, or like more widespread white matter involvement in cavitating leukoencephalopathies, or cortical subcortical lesions like in MELAS. So we have very different patterns of brain involvement after birth. But what about prenatal presentation? Well, here you have always to bear in mind that again, usually there are multiple antenatal anomalies that are associated with clastic patterns that we can appreciate both on ultrasound and fetal MRI with periventricular echogenicity, irregular ventricle margins, and germinolithic cysts. So classic pattern in this context of polyhydrodrums, arthrogryposis, or cardiopathies can raise the suspicion of a mitochondrial disease. One of the subtypes of mitochondrial disease that can frequently present in the neonatal age is the pyruvate dehydrogenase deficiency. We have now 5 genes that encode for the PDHC subunit in the respiratory chains that are responsible for these conditions. And among the different neurological phenotypes, there is also a neonatal presentation with encephalopathy and lactic acidosis. This is one of our cases. On MRI, there is this typical appearance of a PVL-like white matter reduction with squared lateral ventricles, plus germinolithic cysts, some corpus callosum hypoplasia, and ventricular septations. This is a rather typical presentation that should raise the suspicion of PDA's deficiency in the right clinical context. What about fetal MRI? Fetal presentation is similar. We can see some gyral anomalies, ventriculomegaly, and also reduced white matter volume with sometimes this PVL-like pattern and squared lateral ventricles, white matter cavitations, germinolithic cyst, and callosal hypoplasia. These cases are from the literature. So that's important to remind that in this condition, you may have also these PVL-like patterns that differentiate from the germinolytic cyst for the localization of the cyst above the lateral ventricles. And here you can appreciate another case in the neonatal phase where you can nicely depict the same findings. So again, germinolytic cysts that can be multiple, extending posteriorly, very large, plus some ventricular septations, which are quite typical when they are multiple, oblique, in the context of this condition. And if we look carefully, this should be differentiated from other conditions that may present with ventricular septation, such as congenital infection, and CMV is one of those that can present with typically occipital ventricular septation plus cortical malformation, pericylium polymicrogyria in this case. But in this case, you know that the typical anterior temporal lobe cysts may help in the differential diagnosis because it are not seen in PDH, but are actually a typical finding in CMV. So as we have seen, there are callosal malformation also in PDH, and these are not the only metabolic condition that can present with abnormal corpus callosum. Another one is the non-ketotic hyperglycemia that can also have a fetal presentation with typical small corpus callosum, or you can also have large corpus callosum, such as in Zellweger syndrome. But let's move to POLG related disorders that are other mitochondrial diseases that can have developmental anomalies. Here in this case, it's a neonate. You have a very, very small unlobulated cerebellum that was confirmed on pathology since the neonate died quite soon after birth, associated with several brain calcifications. And as you can see here, this was the second pregnancy, and the same findings are seen in utero, in fetal MRI, with exception of calcification that were not visible, but the cerebellum was smaller and unlobulated. And this gives me the opportunity to remember that frequently in metabolic disease, we see both developmental arrest and destruction. And also, this can be very severe, as in the case of pontocerebellar hypoplasia that you can see here in neonatal case, with very flattened pons and small brainstem, very small and atrophic vermis, plus on coronal, this peculiar shape that has been called a dragonfly sign, where there is a relatively sparing on coronal of the vermis and more hemispheric involvements, as you can appreciate here, leading to this shape of a dragonfly. Among the many different types of PCH, there are also mitochondrial diseases. Type 6 is one of them, and neonates can present with generalized hypotonia, poor sucking, limb spasticity. Sometimes even in utero, patients can have these kind of seizures and very bizarre hiccups that the mother can feel. On fetal MRI, again, you can see that there is a very, very small cerebellum and flattened pons. Remember that PCH can also be a presentation of other metabolic disease like congenital disorder of glycosylation type 1A and ATAD3A related disorder. But also, this can be a sign of extreme prematurity in case of hemorrhage of the cerebellum that will lead on postnatal imaging very similar appearance of PCH. Let's move for the next couple of minutes to Alexander disease. In this case, this is an astrocytopathy in which there is an accumulation of misfolded proteins due to mutation of the GFAP gene. We have two forms, and this is the example on MRI of what you can see. You have usually leukoencephalopathy with a prevalent frontal involvement associated with the regions of contrast enhancement, as you can see here, focally in the brainstem. What about the neonatal form. Well, here we have also white matter signal alterations with an anterior to posterior gradient. As you can appreciate, sometimes you can also notice some periventricular rim that is hyperintense on T1 and hyperintense on T2. And interestingly enough, there can be some mass-like appearance of the optic chiasm, hypothalamus, but also here the midbrain. And in this particular case, but also other in literature, this can lead to the presentation with hydrocephalus due to the stenosis of the cerebral aqueduct. And what about the fetal presentation? Here it's a case of diffuse symmetrical thickening, again, of the optic chiasm, associated with thickening of the fornices that was then proven also on postmortem MRI, associated with some bright T1 signal in the frontal lobe that was not confirmed postnatally. And this is another case, again, from the literature, where you can appreciate that this enlargement of the fornices is actually progressive along the course of the pregnancy and confirmed on postnatal imaging, also with some contrast enhancement. So very kind of a tumor-like, mass-like appearance of some structures in the brain, which give me the opportunity to remember that these findings should be differentiated from other congenital brain masses. More typically, we have congenital tumors that present as masses in the brain. As you can see here, some examples, but also remember that we can have rarer diagnosis, as in the case of Alexander disease, in the location that I showed you before, and also in cortical malformations like hemimegalencephaly that can early present with this mass-like appearance, highly cellulated with restricted diffusion in the frontal lobe. So let's finish with some comments on fetal MR spectroscopy, since in postnatal MRI, it's used to differentiate some types of metabolic conditions. In utero, it is feasible. It has been proven to be feasible, especially in the basal ganglia. There are some methodological challenges, but we can actually depict the biochemical fingerprints of the rapid changes in the gliogenesis, neurogenesis, and myelination in the fetus. Of course, normal development is still a dynamic concept that should be better explored on fetal MR spectroscopy. Sometimes we can see signs of abnormalities, even on spectroscopy, such in this case where you can see an elevated lactate in the context of ischemic events, but also some other findings have been detected, like increased creatinine gliosis or increased amino acid peaks in infection. But this should be still explored in the context of metabolic disease. So this is to conclude. Fetal brain can have different abnormalities in the context of metabolic diseases. These are typically non-specific findings, but should raise the suspicion of a mitochondrial or other type of metabolic disease. And it's important, especially if they are found in the association with other multi-organ presentation and involvement. And with this, I thank you for your attention. I would like to thank my colleagues of the neuroradiology unit at the Gaslini Children's Hospital in Genova. And of course, we all know that prenatal diagnosis is a team concept, and therefore I would like to thank Professor Palladini, with whom I work on an everyday basis, and with whom I really enjoy doing prenatal diagnosis on fetal MRI. Thank you very much again.
Thank you so much, Dr. Severino, for a very insightful talk. She's connected with us right now to take any questions. So does the audience have any questions for her? Yeah. Just a moment, Prof. There is a question for you.
Thank you, ma'am, for the wonderful talk. Ma'am, I wanted to know that since mitochondrial disorders are science can be seen antenatally also in some case, some disorders like you have shown in pontocerebellar hypoplasia type 6, it can be sign can be seen. So is mitochondrial genome sequencing done in fetal antenatal cases also? And whether in which brain science we should order for mitochondrial genome sequencing?
Well, thank you for the question. This is a very difficult question for me, since I'm a pediatric neuroradiologist. I'm not an expert in genetics. I suppose that it can be feasible. However, it will gather results that are difficult to interpret. We know already that exome sequencing of the genome is actually providing insights when you have a good phenotype in utero, but mitochondrial DNA is even more difficult to explore. So I think that this question should be asked to the genetician in the room. We don't have this kind of experience in our institution. We don't do mitochondrial sequencing in utero, if this was the question. So I'm curious to know the opinion of the geneticians.
Thank you. Thank you so much. And now we move on to the next and a very, very interesting session. Dr. Hriday Acharya is going to talk to us about what the ideal posture should be during an ultrasound scan. Dr. Hriday, please.
So we have been talking about the fetal spine and the fetal brains throughout these 3 days, and for more than 30 hours, you have been sitting. I hope your backs are not paining. So it's time that we talk about our own backs of the sonologists who have been working so hard to take care of the fetuses. So how important is your posture and how much does it matter? The first thing is, does it matter more than your profession? So to begin, evolution is a very constant thing. So the sonography machines evolved from the E mode simple scans to scans that occupy the entire rooms, to a more compact ones, and to the most recent ones that you see, which are more like video games. So the old scan are like old buildings, and the new scan machines are like the new buildings having so much cantilevers in them. These scans are like modern architectural marvels, which give you better cuts, better function, better diagnosis, and awe-striking images. And I can just go on and go forth. So it's like Netflix of scans. When you sit on the machine, you just go on like watching a movie. But it has some cons associated, like knowingly and unknowingly. Whenever you are sitting on your machines, you sit for long times with awkward postures and a long time to be immobilized, which causes a reverse evolution, giving you a very worse posture which you would have never imagined. So statistically, 90% of the clinicians experience such symptoms. So if I could have a raise of hands, anybody who would have ever had a shoulder pain, elbow pain, back pain, neck pain, maybe hands and everything that's paining at the end of the day. So I see a 90% already in the crowd, which is costing at least $120 billion annually, directly or indirectly, to the employer or to the employee who is working. So, but how does this all start? It all starts with fatigue that goes down to discomfort, to pain, injury of the muscles because of recurrent pain, and last is disability. Most of you would either come to us as surgeons or take medicines when you experience pain, but we can actually prevent it at this level, that's fatigue. And today it's all about prevention. So clinically, it can be divided into 3 stages. The early stages, when you work, is when you have pain. So when you go into the clinic, start working, it starts paining, and at the end of the day, you are comfortable and you go home without pain. The intermediate stage is that even at the end of the day, you have pain, but you wake up pain-free because you have a good night rest. And the late stage, when it's aching and paining for the entire day, on duty or off duty. So this is a lady doing scans, and from an orthopedic surgeon's eye, it looks like this. So when we see, the most commonly associated areas of pain are the neck, the lower back, the shoulders, the elbows, and the wrist, which I would club them as extremities. So now let's start with each part, what causes pain and how can we actually prevent them. The neck. So the first thing here we see is this cute little sonologist scanning, and the prolonged extension of the neck is something that is causing the first thing, that is the neck pain. This causes fatigue and repeated exposure causes injury. So the first suggestion would be try to keep your head in as much neutral position as possible. This can be either by raising your chair up or bringing the screen down. So this is the most ideal posture. So a short video clip that will help you understand. So we can see this lady is having neck pain, looking at the screen that's too high. So this lady comes, she's somebody who is me right now, helping her adjust the screen, looking exactly in the line, making her neck so comfortable. So that's how your screen should be. The next thing is a simple law of physics where we know that as the moment arm becomes longer and longer, the more force is you need to act upon. So here, this guy is the neck and the moment arm is the distance of the hand when you work on your screens or on your computers. So as the screen goes away or the patient becomes further away from you, the more and more pressure your neck has to do, and that causes neck pain. So most importantly, avoid reaching out. Keep your hand as close to your body as possible. The keyboard should be within your reach. Never extend your arms away. So to advise regarding neck pain, keep your screens in line of your eyes. Things should be within the reach of your hands. Reaching out is strenuous both to your neck and your arms and your back. So the patient position can be adjusted and your sonography machine can be adjusted. And most importantly, recharge. Between every patient or between few patients, if you have neck pain, just lay your head in a reclining position and that will help you relieve. The next are extremities. So the arms and the wrist should be in proper position. So should be the elbows. Here we see this lady with abducted shoulders and extended elbow, which is a very normal USG scan room picture, but a very discomfortable one. Similarly, the wrist should neither be in extreme of the position. So this is another video which demonstrates that this lady looks very normal, but her arm is extended more than 30 degrees. So first, pull the patient as close to your body as possible. Secondly, always have a table that's adjustable or a chair that's adjustable so that you can have it within the reach. Have a support under your elbow so that everything in the body, all the joints are supported, causing the least strain possible to your body. The last is the back. So probably these are the WhatsApp images that we'll be seeing during the COVID times, the most common ones. So what they say is avoid slouching. But why? So when just zooming in on your lower back, when you are sitting erect, the force of gravity or the force goes behind the back. So that is why these are the bones and these white lines we see are the disc. So whenever you sit erect, all the forces go behind the disc, causing the least back pain. But when you slouch, all the forces go through the disc, causing excessive strain on the disc, causing back pains. So avoid slouching and sit erect as much as possible. This might cause discomfort. You might have thakan, as we say, when you sit erect, but you won't have pain for sure. So this is a very important photograph which demonstrates the amount of load on your back. So the most simple is when we sleep, which is around 25, and when we stand is 100. So when you sit, it's almost 140, which is as worse as bending forward. All of us as laymen, as doctors know that bending forward causes slip disc. So bending forward is equal to sitting, and when we slouch, it's worse than bending forward. So it said that sitting is the new smoking, and so avoid sitting as much as possible. So as a rule, get up between two patients. So between two patients, get up for reporting, get up to counsel the patient, whatever you can, but get up from your seat between two patients. So this is an ideal photograph of a sitting person doing a USG The line of the screen is in line of his eyes. The back is straight. The angles are perfect 90. The machine is at an ideal height. So this is an ideal thing, and try if you can. Looking from the back, this is how somebody will look. And to an orthopedic surgeon, he will look like this. So one simple conclusion, instead of being this, it would be great if you could work like that. So before we end, so how to prevent and manage the pains is one common question that everybody will be having in your mind. So we started with this architectural marvel, and we know that to have such a marvel constructed, it should have a very strong core. And so should you, because you have been moving around. As far as strengthening of core is concerned, it can be divided into two simple halves. First is endurance. The second is strength. So endurance can be walking, cycling, swimming, any of these which will help you build your stamina is what we call. And in a recently published article that I just published was neck pain in spine surgeons. The incidence was pretty high, but the only statistically significant thing that reduced neck pain was exercising at least thrice a week. The next are stretches and exercises that all of you can do in your OPDs, in your lunch breaks, or in between patients. So I'll just give a brief about them. The first are stretches behind your hand. So just put your hand here and stretch it. So this is about stretching your trapezius. The trapezius has 3 fibers. One that helps, the first are the upper fibers. So this will help stretch upper fibers. Putting your hands behind your waist and stretching. These are the lower fibers. You can stretch right now. I already feel a bit relaxed after doing that. The third are Supermans. And last are wall standing. So wall standing is something that would give you a reference about standing straight. Most commonly, as we slouch, we flex, and we don't know how much we slouch. Standing against the wall would give us a reference about what is straight, and just standing for 30 seconds every 3 or 4 hours will really help. Regarding back strengthening, we would include cobra poses, planks, ab strengthening, prone leg extension, so on and so forth. So just to conclude, the first is always report any pain that you have and don't disregard it. Always take intermittent rest. Just lay your head flat, just stand up, whatever you can. Be thoughtful about your posture. And last but not the least, always exercise.
Brilliant.
So
Brilliant.
take care of your posture for a healthier and a pain-free professional career. Thank you so much.
I'm sure everybody will have a lot of questions for you. Do you have a consulting room here set up?
Yeah, so happy to answer the question.
Thank you so much, Dr. Hriday. I think the whole conference has been brilliant. Dr. Prashant and the entire society has put together multiple talks that are going to be so useful for our patients. This talk is so useful for us so that we don't become the patients. Like you said, we shouldn't become our own patients. And I think this is something that we should remember. And I was telling everybody here, I start off with a very straight posture and then I de-evolve. You know, as we're concentrating, we're so into our cases. I don't even realize I'm leaning to one side, I'm slouching. But then this is something that we must remember and make sure that in between, at least not every patient, in between a few patients, we should sit up, take some little, rolling exercise. Yeah. Would you advise something for the eyes as well? Because I feel eyes are also strained a lot for us as radiologists and as fetal imaging specialists.
So it's not my field, so I can't advise something that is very true. But the only thing that anybody, as far as since we deal with limb spine, so anybody demands is rest. And so I cannot tell you to just lie down and sleep, but intermittent rest is something like in between 2 patients, if you can spare a 30 minutes just to close your eyes, maybe that can help. 30 seconds is fine.
Hello. Doctor, you have touched every part. You have not touched the wrist. Most of the time, the carpal tunnel syndrome type of thing happens. I think it is due to the proper holding of the probe.
Yeah. The carpal tunnel syndrome, as you said, is because of extensive flexion of the wrist that happens. It compresses the nerve. So always be mindful of the posture is all I can say, because you cannot just have a brace in your hand and scan.
It is the problem is with us only. You hold the probe as if probe has got 4 legs and is going to run off. So hold it lightly. There is no point in, oh, and you do the scan like this. No point. Hold it very lightly, and the movement should be with your fingers, not even with the wrist. Okay, the movement with the finger will move your probe in millimeters. Movement from wrist will make you in centimeters. And the moment you start involving your elbow and the shoulder, the probe will move in a foot. Right? So you don't see anything in the fetus. You want movement in the millimeter distance. And that's where only your finger counts. So loose holding the probe and moving with the fingers. Don't bother your wrist to work.
As I said, you need a consulting room.
Yeah, you need a consulting room. First of all, thank you for a nice lecture. It was a temptation to go for shopping or to attend your lecture. So I thought.
I feel really glad for a lady telling that.
Yeah. So it's not only a lady, it's a lady with back pain, neck pain, hand pain, and and for this, you were asking about the pain. So I have a share because, of course, I'm Subuhi Rizvi, and I have. So at this stage of my life, when I've crossed 50 and I have done with my teenage daughters and taking care of elderly and an ultrasonologist, I have not left obstetrics. So I have a share that's called "Ek do dard nahi, sara badan hai zakhmi, dard bichara pareshan hai kahan se uthe." So it's like everything is paining and it's not resting. And of course, for you, for males, it is you go back home and rest. For us, we go back home and we are in another avatar. We put down a crown and we are managing for the elderlies are fed, the attendants are taking care of everything. So I think the females are slightly more overstressed in India, in spite of having the best of husbands who can send us to the conferences. So because the man of
You are blaming. Oh, it's terrible.
No, let's be honest about.
Thank you.
honest
No, you are
about
right.
it, yeah.
I totally agree with you.
So I think with the supplementation and the posture, I went for this, like I do the yoga and the strength training also, which injured my knee again. So I'm having a kneecap right now. So I think we are trying to do too many things and we are landing up. In
I
other things. So
personally
thank you
feel-
for the nice.
I
lecture.
personally feel we should take. I have a.
Yes. Hi, my name is Waldek. I am from Poland. In my life, I exceeded 2 years ago 100,000 scans. My hips are now have to be exchanged. I have a questions. On daily basis, I perform neurosonography using standing position. I have a table which goes up and goes down. And this is maybe, I don't know, you know how to this scan looks like. In one hand, you have a probe, and the second hand is on the baby and maneuver the fetus. Please, maybe you can give us a hint how to do this more safely and something like that.
So yeah, so yesterday I was I just saw Dr. Poo's lecture. She does the standing transvaginal scans is one of the pictures which she showed, and it was a very not so comforting to the eye kind of bag that she had. So this is I just see like that. So if possible, what you can do is pull the patient closer if you can, or you go closer to the patient if it is. The only problem that happens is you are using the normal table where you can get the patient supine and you can even do a transvaginal and transabdominal scan. So if you can come closer to the patient, have your probe like a cut tables that generally a lot of patients doctors use in gynecological ward. So a cut chair with leg pieces would actually help you reach closer to the table. That would actually help you avoid reaching out. Once you won't reach out, your hands will also be in a better position to maneuver the baby. This is the discomfort is because you stand too far away from the belly and from the vagina or from the probe. So that's why just go as close as you can. Have tables which generally are used for deliveries where you have cut so that you can go as close as you can.
In Poland, we also have a big problem with obese women. This is the first thing. And
So
the
always use assistance.
Yes, yes,
I
yes,
had
yes.
a
Yes,
slide,
I
but
know. And the
couldn't have
second,
time.
and the second issue is that the more gestational age is higher, the scan is harder. Yes, because the school is big, the acoustic windows are narrow, and you have to sometimes be like a rabbit, yes, and one hand you squeeze the baby's head, the second hand you move the probe. Sometimes 3D helps with that, because you can take you can took a volume and then proceed with this volume, and sometimes you have to fight.
Yeah, so the another thing that you can try is divide the scan. Maybe do first half of it, take another patient with more simpler, and then rescan the patient for the rest of the anomaly. If you just arbitrarily, if your examination is divided into 3 parts, part A, part B, part C, you can do 2 parts, pick a simpler patient and go to the part C so that you get some rest, or you don't need to strain for a longer period of time.
Now each second scan I stand.
Yeah, that's the best thing. Thank you
I
so
think
much.
we are running out of time. Thank you so much. I would like to invite our next speaker, Dr. Lokesh Lignappa. He's from Hyderabad, Telangana, and consultant child and adults and neurologist, Rainbow Hospitals, Hyderabad. The special interest in critical care neurology and infantile epilepsy and stroke is going to throw some lights on postnatal CNS malformations and their outcomes in India. Is the practice same or different? After the sessions, there will be announcement of prizes for the poster and paper presentations.
Thank you. I think Dr. Uday has said I think he had the most questions to battle as compared to any other speaker. I think all of you should also make sure you take your vitamin D monthly without miss. You ask your representative whoever comes to supply the vitamin D to all the staff. I think that's one thing, because we are all indoors, and unless proved otherwise, we are vitamin D deficient. Yeah, I think I'll just modify the talk a little bit as compared to what this one is, topic one is. The question was whether postnatal malformation, structural malformations, what has been picked up, whether the outcomes and follow-ups are different. Answer is no, it is not different, because the disease is same and the medicine is same, so it is not going to be different, but the support systems are different, and maybe because of loss of land and other things, there might be slight differences in the way we look after this. But we have very good fetal medicine backup in most of the tier 1 cities and getting into tier 2 cities, which the support system is good. Genetic expertise is getting better and better, and the testing is becoming cheaper and cheaper, so you are able to diagnose them very accurately. And in last 10 years, we have more than 600 pediatric neurologists who are across India, but there is a lot of discrepancy in Northeast and other places. They are less in number, but otherwise you have enough pediatric neurologists to care for them. And as an interface from fetal medicine consults, we usually get referral from fetal medicine as a pediatric neurologist, from obstetricians or a fetal radiologist. And most of the consults are for usually ventriculomegalies, which are not beyond 15 millimeters. Beyond 15 millimeters, it's a straight away you say don't continue. But when it is more mild to moderate, that's when we get the consults. And corpus callosal abnormalities, we had some discussion already. And spinal abnormalities, once again, mostly now occult ones, and the posterior fossa abnormalities. And the most common one where we play a role and we interact with you would be a previous SIB with a neurogenetic disorder or developmental delay, and where we need to make accurate diagnosis, and then they come to you for the next child. So I'll just go through few case examples, how it goes through and what our role would be and how we are partnering with few people. So this is the first child. Second, we saw the second child who was born, term newborn, no antenatal complications, noted to have breathing difficulties, irregular ataxic breathing, and pauses, variable pauses and apneas were there, and required intermittent bagging in the newborn period. They had normal head circumference, but had a post-axial polydactyly, indicating there is some underlying genetic abnormality, had generalized hypotonia and required initial ventilation for 10 days and weaned. So here we are looking at a consanguineous family. When we went back into the history, the consanguineous child, firstborn child, no perinatal issues, but had developmental delay, walked at around 7-8 years of age, had post-axial polydactyly, but was very rudimentary. On examination, we had a very rudimentary polydactyly, and CT brain was interpreted as periventricular leukomalacia. And this is a child, the first child was born, and when we examined this child, so the eye movement, so you can look at the eyes, the child is looking from one side and then he turns the head rather than moving the eye. So this sign is called oculomotor apraxia. The combination of oculomotor apraxia with polydactyly generally points towards a inherited brain ciliopathy spectrum, that is Joubert syndrome. So when we look back at the CT scan of the first child, this is what the scan is. Anybody in the audience? Molar tooth sign. So, but interpreted as periventricular leukomalacia, and told that there is no risk of recurrence next time. So this family had a second child with Joubert syndrome. So that is why it's very important to reinterpret all the investigations, re-examine the child before telling the risk of recurrence, what is it, whether there is a need for this one. Because even though your genetics might be negative, you pick this up very well in the antenatal period and counsel them accordingly. Okay. So we had around 59 children with Joubert syndrome from 55 families, where we did a genetic testing in 35 families. And Joubert syndrome with pure Joubert syndrome was around 60%, and with retinal disease around 22%, and polydactyly was noted in 8.5 of them. And some of them had Leber's congenital amaurosis as well. So, and the commonest gene which we found in our population was CEP290, which accounted for almost 40% of the Joubert syndrome in our population. And of this, we had an antenatal diagnosis in 6, and there are 3 of the pregnancies were affected, which had to be terminated because they have very variable outcome. The cognitive outcome is different, the motor outcomes are different. Some of them develop renal failure. We recently had a child with renal failure at 6 years of age. So they can have significant retinal disease as well. So there's morbidities are quite multi-pronged, so it's better not to continue these pregnancies. So lesson, first child with developmental delay, always reevaluate the diagnosis, including the imaging yourself. So generally, we don't look at the reports. They say, sir, we have the reports, can't you look at it? We said, no, please get the films, we'll have to look at it and then interpret it based on that. And clinical examination, the rudimentary polydactyly was a clue again in this child, along with the oculomotor apraxia. Always have a reliable radiology partner in this sort of situation. So this is another child where third trimester, around 32 weeks, there was noted to have corpus callosal hypoplasia. This is a postnatal scan in the neonatal period. You can see significant thinning and the genu is almost not there. So the head circumference was 3rd centile, weight was 50th centile, indicating that there is some cerebral pathology which was going on antenatally. There was no dysmorphism or organomegaly, and head log was there. Extraocular movements were full with significant hypotonia. Once again, the child had respiratory failure with seizures. You can see there is lytic lesions in the bilateral basal ganglia complex. So whenever you have this kind of combination, you are looking at, once again, mitochondrial disorder as already presented in the previous talk. So in view of these clinical findings, blood lactate and CSF lactate were done, which were elevated, and MRI brain features were suggestive of mitochondrial disorders, and WS and mitochondrial genome sequencing, which were sent, didn't return any abnormalities, which is this case in almost around 40% of cases. You don't get a genetic cancer in this situation. So then we entered with a muscle biopsy. We can do the respiratory enzyme analysis. It is done only at imhance. The muscle has preserved at -70 degrees and has to be transported like that to get the respiratory enzyme analysis, which showed there is evidence of complex 1 predominantly and to a certain extent complex 4 deficiency. So now the family wants next child. So what do we have? How can we counsel this family? Very difficult, isn't it? So because you don't have a genetic cancer, and then you cannot counsel them further this one, there is always a risk of more than 25% of recurrence in next pregnancy. That is when I think the people from Newcastle upon Tyne from UK has tried this. You people are aware of this? Mitochondrial donation. So that is a, yeah. So I think this is a very innovative way of doing things in these families with mitochondrial disorder. So that this is just first baby which has been delivered in May 2023. So I think it might, if it succeeds well, if the follow-up, the development of this child is good, it might be coming to use on a larger scale. So this is a poster presented by one of our trainee on polymicrogyria. I'll just take out the, so we had around 73 children as a cross-sectional study with the polymicrogyria. And then after 30 of the 73 had consanguinity, and antenatally, only 4 of them were referred to as antenatal diagnosis in the late trimester. And another 10 had some abnormality picked up in the antenatal scans. The rest of them, there are no abnormality picked up on the antenatal scan. Almost around 60 of the 73, we didn't have any fluke the antenatal period. So most common were perisylvian polymicrogyria, which was seen in the this one, and then followed by generalized polymicrogyria. And the commonest mutation what we found in the population was ADGRG1, which accounted for 7 of the 30 patients where we did the genetic testing. So these were all the different genes which we could pick up in our population of polymicrogyria. So although I think I'm not sure what age you generally will be able to pick them up in antenatal scans. What age do you generally pick up polymicrogyrias? Yeah, okay. So that's why we didn't have them picked up very early. This is a child with spastic diplegia, 3-year-old term child, first born, evaluated extensively for spastic diplegia. MRI brain was normal. TMS was tandem mass spectroscopy looked for some of the metabolic abnormalities were normal. Whole exome sequencing was negative. Parents are concerned about the prognosis of the current child and recurrence in next pregnancy. Then what do we do? And we looked at the scan, the MRI scan of sagittal section. Can you see where the arrow is pointing? There is a narrowing and there is a gliosis. So this is one of the complication in breech delivery, breech extraction. You develop hyperextension or hyperflexion of the neck where it causes cervical cord injury and spastic diplegia. So there, if you are not looking at the scan properly, even in the normal MRI brain, if you look at the sagittal section, you will be able to pick this up. So this was missed and extensive evaluation, including genetics, was done. So it's a non-recurrent pathology. At least one part is you can say it is a non-recurrent pathology. And then you can ask them to, if they are planning next pregnancy, they don't need another genetic. So this other child with neonatal seizures and encephalopathy, once again consanguineous family, day 5 seizures, multiple episodes, controlled on 3 anti-seizure medications. And these are the scans in the neonatal period. So you can see there are squaring of ventricles of the frontal horns and cystic changes here in the periventricular white matter, predominantly frontal, symmetrical almost. So do we think it is HIE? Yeah, significant corpus callosal thinking. So it's the intrauterine process. So this child had molybdenum cofactor deficiency. So if you don't look at, if they just come with a scan and you don't think of it critically, you might pass it off as a perinatal asphyxia in the neonatal, with the neonatal seizures. So refractory seizures, because most of the HIE seizures, they stop within first 3 to 4 days. After that, they don't continue. That will be a clue to most of the clinical. Yes. Good. Yeah. So this is a term newborn, no perinatal asphyxia once again, had multiple seizures from day 2 of life. And because there are multiple seizures, normal MRI, normal metabolic investigations, the geneticist asked for a whole exome trio. And the whole exome trio was reported as normal. So then the child came for a second opinion. Then we saw this child. This is what I'll, yeah. So just see what's happening. So when you tap around the nose, there is a startle. So it is called primary hyperexia. It's a glycine receptor abnormality where the MRI is normal. They can have multiple seizures. When we called up the geneticist lab and said, this child has primary aplexia, within a day they gave this answer. This child has SLC6A5 compound heterozygous mutation causing primary aplexia. What it means is you will do whatever the genetic testing, whatever this one, unless you are doing a focused examination, giving that information to genetic lab, where 1 lakh rupees also can go down the drain. So it's extremely important to have the clinical phenotyping, have the all examination, then you get the answer. So this is a child on follow-up for spastic quadriplegia, refractory epilepsy. So this child had first seizures on day 2 of life. Generally, day 1, day 2 seizures, unless proved otherwise, is the perinatal hypoxia. That's the usual thing. For basal ganglia pathology was noted, we thought of as acute hypoxia. Then the mother called me at 26 weeks of pregnancy, second pregnancy, that the fetal MRI was reported as abnormal. What are we seeing here? Lytic lesions in the basal ganglia complex, which are symmetrical. So you are looking at some recurrent pathology, which is involving the basal ganglia complex, can be mitochondrial or some other pathology. And when we went back at the first child's MRI, so there was very small cysts here, but more importantly, there was a lot of rarefaction which was happening. You can see the rarefaction here of the white matter, more in the temporal lobes as well. So something which is causing rarefaction of white matter, basal ganglia lytic lesions. Then we ran the genetic testing, which picked up a gene called MDH mutation, which is malate dehydrogenase deficiency. And when we look back, it was in 2017, and just 1 month before, there was a case series which was published of which causing a Krebs cycle enzyme, which causes a significant neonatal encephalopathy and epilepsy. So that first child was born on 2014. At that time, it was not described, and then now we had this diagnosis. So then, because we had picked up, there was another child with similar early onset epilepsy. They had reported MDH2. We thought we had MDH2. And then, but when the initial MRI was done, the basal ganglia complex were looking very clean. So we repeated a MRI at 3 years. Still, the MRI basal ganglia are very clean. Most of the patient series had basal ganglia abnormal. Then we went back to the genetics, said they are missing out on something, reanalyzed. Then they picked up a mutation in something called KCTD7, which causes progressive myoclonic epilepsy. So the genetics sometimes can come with some answers, but if the clinical phenotype or the course is not matching, go back to the genetic team once again. So then we did an antenatal for the next pregnancy, and the next child is now 2 years, she is fine. So we published a paper with the Canadian group recently. This week it was published. So this is another child, me and Dr. Madhavi Noori, who is here. We work together, who is our fetal radiologist. So this is a firstborn child, 3rd degree, non-consanguineous parents. The child had intellectual delay. She was walking around. She was able to understand simple things, but she was dependent for all her activities of daily living. Mother was very educated up to 5th standard, but she said, if there is a chance of recurrence, I will not continue the pregnancy. So let me help me. So she was at 20 weeks of pregnancy. They brought the MRI of the first child. So if you see carefully, there is squaring of ventricles here. There is a small nodule here. Periventricular nodular heterotopia. No other features of clinical features or radiological features of tuberous sclerosis complex. So this was the only clue for us to say, okay, this child have some genetic diagnosis. So sent off the genetics, then we got the ACTB mutation, which was heterozygous, and this was at 24 weeks. And when you look at that, that causes Barrester-Vinton syndrome, which causes developmental delay, intellectual delay, band heterotopias, or simple heterotopias as well. Listens of multiple abnormalities can be seen. So it's a reasonable match. So then we cannot do a genetic diagnosis for the fetus. It's already 24 weeks. Then I went back to Dr. Madhavi Noori and asked, can we look at the fetal MRI? And then these were the images. I hope you can see this. Bumpy nodules here of gray matter in the periventricular region. So the same thing was in the index child, and this was explained to the family that there is a risk of recurrence of the similar thing. Mother was very clear. Although this child is walking around and able to do, but I'm able to having to do everything for the child, even at 8 years. I don't want the pregnancy to continue, so they terminated. So it's a teamwork once again. Sometimes genetics, radiology, fetal medicine, everything coming together to give the right outcome to the families. So then this is the last case. I think we have been discussing about this case since morning. I still have some questions. So asymmetric ventriculomegaly, mother is a gynecologist, father is a pediatrician. At 26 weeks, they come to us with the asymmetric ventriculomegaly, and there is a small germinal matrix. So this was almost 4, 5, 6 years back. And then we counseled that there is a risk of left hemiparesis, maybe some cognitive delay or some epilepsy is possible. but the definitive thing would be there was some degree of left-sided hemiparesis. They decided to continue the pregnancy. So then on follow-up, he had refractory epilepsy, epileptic spasms. He has Lennox-Gastaut syndrome, 50 drop attacks a day, every day, in spite of all the medications, ketogenic diet, everything tried. Surgery was considered, parents epilepsy surgery. So where did we go wrong? So the postnatal scans not showing much, some white matter abnormalities. This is the ventriculomegaly which is persistent still. So congenital hemiparesis, sorry. Yeah. So congenital hemiparesis, refractory epilepsy going on to the LGS, stagnation of motor and cognitive milestones. And this is where we are looking at for the answers. Anybody? Yeah, so it is collagenopathy, COL4A1 mutation. So this child had a COL4A1 heterozygous mutation. Parental testing was negative. It was a de novo mutation which caused this abnormality. So it can cause varied spectrum of abnormalities. So when we went back and reviewed the literature, yeah, this is the last slide. So in a case series of almost around 56 patients who had COL4A1, when they looked at the fetal information, 47 of them which was available, one of the common thing what they have found is fetal ventriculomegaly is one of the common feature, which is very non-specific once again. But if it is asymmetric associated with a bleed, then it makes it more likely to be a collagenopathy. They can have posterior fossa abnormalities, Dandy-Walker malformation. If you have a fetal growth restriction with ventriculomegaly, it's more likely to have COL4A1. And then also one study looked at the multifocal hemorrhagic lesions in fetus. If you have severe or multifocal hemorrhages or multifocal ischemic hemorrhagic lesions with or without associated cysencephaly or porencephalic cyst, then they looked at whether they have mutation or no mutation. Where they came up with a very interesting information that if they have mutation, the bleeding and other abnormalities happen around 24 to around average of 24 weeks. But if they don't have mutation, they have it somewhere around 32 weeks. So I think that is a useful clue for us to say whom we have to test for these collagenopathies. But it's a very small numbers. I think still when to test for these collagenopathies is still out. But these are some of the clues when to look for this collagenopathies. These are the various abnormalities that can be seen. So the interface between pediatric neurology, fetal medicine, genetics, fetal radiology is very interdependent. We need to talk to each other. It has to be a two-way communication always, and appropriate investigations, reinterpretation of many of these testings is extremely important to have safe fetal outcomes. This is our team. Thank you.
Can I request Laurent? Can you honor Dr. Lokesh? He is one of the best pediatric neurologists in the country. This is for you. Wait. This is our Ashok stamp. It's Marco.
Next, we'll have our own dearest Dr. Prashant sir rounding up the conferences program with thumb rules in fetal neurosonogram.
I hope you are tired and your mind. I think you need to have at least 6 cerebrums to collect everything. So you can't have 2 hemispheres and you can remember everything. So you need to have 6 cerebrums, and so that means 12 hemispheres. Let me make your life little easy. Now Galileo has given one simple measure, and we are after it. Measure what is measurable and make measurable what is not so. The meaning is simple. You should measure everything. If you can't measure, make it measurable. And the moment you make it measurable, then you will try to separate, is it normal or abnormal? Is it small or is it too big? And then we try to create, okay, this group is normal, this group is abnormally large, and this group is abnormally small. And in medical terminology, we call it the less than 5th centile, more than 95th centile, because we consider statistically that the group which is falling between 5th to 95th centile is considered as a normal. And above or below, we don't consider them as a normal, which may be normal because it is statistical possibilities. That is the reason the organ, length of the organ or the measurement of organ always does not follow the rule, which we expect to follow. And that's the reason we start on OB ultrasound from BPD, we start to measure everything. Okay, and because it is possible now, because we started with biparallel distance in A plane to can be measuring the tactile plate thickness, thinness. We are measuring whatever which is seen on the screen, we try to measure and quantify. So because there are so many tables, and because there are so many tables, will you be able to remember? That is my position when I see any kind of the table. Okay, so I thought that it's not possible for me to remember because I have got a very small brain and I can't remember. I got very small memory, so I can't remember. So that's where a rule of thumb. I thought about that. See, we are Indians from India. Also, I'm Gujarati from the Gujarat, and we understand mathematics probably the best in the globe. Not only in India, we understand the mathematics and the rules, what is going up, what is going down, and how to interpret and what to do for that. So we understand that the most. So that's the reason I thought of let me make my life easy. So we try to make it a rule of thumb. The meaning is a practical and approximate way of doing or measuring something. So let us make life easy. And the first thing is I'm giving you one example. Then we will go to only brain measurement or what is regarding the fetal neurosonogram. A nuchal translucency, everyone measures, right? So before going to nuchal, you try to measure your CRL. And the CRL, you zoom it, and what is mean nuchal translucency? Just prefix 1 to your CRL, that becomes your median. If the CRL is 60 millimeter, 1.60 millimeter is a median NT. So it is same applicable to any gestational age. 50, 1.5, 80, 1.8. Now I have understood, okay, what is normal or what is median. Now I need to understand what is abnormal. Abnormal means I'm talking about more than 95th centile. So instead of prefixing 1, you have to prefix 2. When you can prefix 2, it becomes automatically more than 95th centile. And the moment you prefix 3, if your NT is like that, it is above 99th centile, and that is in a very small little group that it needs further evaluation by mostly doing invasive testing. So that is the simplest of all thumb rule which we have produced. And going to the specifically for the fetal brain, you have got intracranial translucency. You know that translucency also is going to vary. And this is one of the marker for your open spinal tube defect. So whatever the gestational age is, say for example, you are dealing at a 12-week of gestation. So 1.2 plus add half of it. So 1.2 plus 0.6, that is 1.8. 1.8 is a normal intracranial lucency. The moment it becomes equal to your gestational age, so if you have to put .1 only, there in the middle of that at 12 week, if it is 1.2, it is small IT, and that means you are talking about below 5th centile. Look at a spine, look at a crash sign or whatever, anything where you are comfortable. Make sure that you understand. You look at a spine and evaluate. When it is double the gestational age, that means you are talking about the posterior fossa cyst and a cystic structure. It is above 95th centile of that's the measurement of. I have put in a reference and I have put in a graph, and so that you can correlate. And I think you have got that book with you in the kit. You can go home. But I'm trying to give you the concept by which we are working. Of course, you can have the Epson corpus callosum, but this is a very crude rule, so I'm not going to give you that measurement easily. Looking for now, let us go for the corpus callosum length. The moment you remember that at 20 week of the gestation, your the length of the corpus callosum is going to be 20 millimeter. That is a nomogram which is shown on your right hand side in the nomogram table. The moment you have remembered this rule, then everything, the life becomes easy. The corpus callosum is going to grow 2 millimeter every week. It's a simple rule. So the moment you feel like that, okay, you are trying to evaluate at 25 week of the gestation. So how much corpus callosum length you are going to expect? 20 plus 10. So it has to be 30 millimeter. It is as good as the simplest of rule. It follows till term, not at between this gestation is following, then again it's not following. So that is one way of looking at it. Now let us, my interest is in identifying the smaller one. Okay. So there is one more rule, is the standard deviation is 1.5 millimeter and it grows by 0.1 millimeter every week. So at 20 week, if the corpus callosum is below 2 standard deviations, so 20 minus 1.5 multiplied by 2, that is 3. So at 20 week, if the corpus callosum is below 17, you should have that, okay, there is something I need to do a detailed evaluation. And this is applied, this rule is applied everywhere. So at the age of 25 millimeter, 25 week of the gestation, where I'm interested is 1.5 plus 0.5, so it becomes 2 millimeter. So 30 minus 4, that means 26. Any corpus callosum length less than 26 millimeter is going to show you the abnormal stuff. That's what I have given you, that kind of information. So moving further, orbital distance, you know that is 1/3, 1/3, 1/3. So I'm not going into it. One typical thing of how much year, because year is a part of your CNS examination, and you are always confused what is the length of the year. Simple rule, 1/3 of your biparietal distance. Anything below, you are anything less than the length of your ear, then 1/3 of the BPD, that is abnormally small and it warrants further investigation. Moving to your transcerebral distance, it has got a typical peculiar kind of follow-up. Less than 24 week, it is equivalent to the gestational age. And after 24 week, you have to add 10% to the gestation. That makes your 50th centile of transcerebellar distance. So primarily, our anomaly scan is going to be almost around before 24 week. So just remember one thumb rule, equal to gestational age is, it has to be, that's a 50th centile. Now, length of the vermis. Craniocaudal height is half of the transcerebellar distance. The simple logic is what? The moment you have got half of the gestational age, that should be your craniocaudal length of the vermis. It is simple. Or the half of the transcerebellar distance is also height of the vermis. So a vermian craniocaudal length, you have to just see what is okay. And the screen, it is showing me 22 weeks. It has to be 11 millimeter. Okay, so that simple rules, the moment you do it, your life becomes a little bit more easier. Again, one thumb rule that, okay, the moment you have got a septum defect, epsom septum pellucidum, I'm going to look for the optic chiasma and going to measure. I've already shown you, but I'm just going to repeat. The optic chiasmal length or the width has to be 1/4 of your gestational age. If it is below that, you are dealing with less than 5th centile of the optic chiasma. And please look up more possibility of septoptic dysplasia, get a detailed evaluation of MR and the fetal pituitary evaluation that needs to be done. Posterior force success, simple. 10, 20, 40, 60. If your brainstem Vermian angle is below 10, it is normal. If it is around 20, you are talking about black pouch cyst. If it is 40, it is you are talking about inferior Vermian hypoplasia. If it is 60, you are talking about Vermian agenesis. So 10, 20, 40, 60. So that will help you in identifying the things. Now, most important is counseling of the patient. The moment you find some kind of neurological deficit, say for example, absent corpus callosum, that there is some kind of malformation, the counseling becomes difficult. If you can't remember everything, if you remember simple one thumb rule, your entire 3-day of the congress, your counseling is going to be very simple. Because there are many references which shows that 27% of the infant with absent corpus callosum over the age of 30 months had a neurodevelopmental delay. And there are a lot many references I can quote, which all says that it will be around 30%. 30% is 1 out of 3. So what we have put it a rule that whenever you have got absent corpus callosum, 1 out of 3 may have a neurodevelopmental delay after the birth if the patient wants to continue, if it is isolated without any association of any other malformations. Other genetic disorders are ruled out. then it is 1 out of 3. Okay, so that should be the counseling in just to make it very casual or easy. Same thing is for the posterior fossa malformation. If you really look at the table which is there, it starts from right from the 100%. From 100% malformation from the Vermean agenesis, there is going to be a when you have got Roman-Cephalosynopsis, there are going to be 100% where cerebellar hypoplasia, you have got a lot of problems. But only one thing which is the list is what you have got, what is mentioned is the Vermean increased Vermean hypoplasia, which is a 28%, 25%. So 25% is 1 out of 4. So that means 1 out of 4 will have at least some kind of neurological deficit after the birth if it is isolated. Very controversial point I am going to discuss about borderline ventriculomegaly. Now, American Journal with the Society of Maternal and Fetal Medicine has given in summary, the last line is very important for us. It says that in the setting of isolated mild ventriculomegaly, 10 to 12 millimeter, the likelihood of survival with a normal neurodevelopmental is more than 90%. I'm not worried about those 90% because patient is not going to come back to me and no, doctor, you have done good thing, my baby is fine, and it is in that group. Who is going to come to you? 10%. From whom you are going to get a legal notice? 10%. I'm worried about those 10%. So I will counsel 10% means you are talking about 1 out of 10. Okay, so 10% is 1 out of 10. That means that the rule is that, yes, you can counsel up to 10. Again, I'm using a lawyer's language, up to 10. That means you may have 5%, you may have 6%, but up to 10%, there are many references which you are going to find it. A word about microcephaly. Now, how do you get less than -3 standard deviation of the your HC? Then you can define it as a microcephaly. That's simple. If the head circumference is less than 8 times of the gestational age, easy to remember and easy to diagnose. If you are dealing at, say, for example, 25 week, and if your head circumference is below 200 millimeter, then you are talking about less than 3 standard deviation. You should start thinking about is it a microcephaly? Should I evaluate? What should I extra evaluation it needs? It is not the diagnosis, but you should have that clue in your mind. I need further evaluation and further kind of discussion. So that is about microcephaly, and that can give you a very simple thing. And last, to remember everything, 1 out of 2, if it is isolated severe ventriculomegaly, 1 out of 2 will have severe neurological handicap. 1 out of 3 in case of isolated absent septum corpus callosum. 1 out of 4 if it is isolated posterior fossa anomalies. 1 out of 5, you have got a chance of septoptic dysplasia in case of absent septum pellucidum, and 1 out of 10 in isolated borderline ventriculomegaly, you may have neurodevelopmental delay. So thank you very much for patient hearing, and thank you very much for being attentive for all 3 days, and hope you must have gained quite a lot of things. And I wish that you should start right from tomorrow, from when we are going to see the patient live or in ultrasound workshop. And there are various workshops. We have Lokesh Lingappa, who is going to take care of the postnatal workshop, who is going to tell you about everything. There is a fetal MRI workshop at a different center where Daniela and the team is going to take care of the MRI workshop. Then there is an ultrasound workshop where we have got I think Dario has left. So we are going to have Gustavo taking lead. We have Ramamurthy. I'll show some of the cases. Andrea is going to show, Lauren is going to show you the cases live. Everyone is given 30 minutes. They are going to show their skill. We are not here to see their skill, but there are practical points what they are going to give you while live scanning. What you see here, the images, they are best of the best images which everyone has got. But on day-to-day examination, how they tackle the situation, that's what we are going to get it. Opus workshop, again, Gustavo and Mauricio, they are going to take care, and along with the Anita. And there Lauren is going to take, also going to be there with an Opus workshop. Anita is going to also be in charge of the Opus workshop. We have Rachna and I think Akshata is going to take care of the workshop. So you have got still 2 or 3 slots which are vacant for Opus. If you want to go in Opus workshop, you can contact them. And of course, then I think which workshop? Genetics. One of the highest level of interest you have got in genetic workshop. We have to change room 3 times. We started with 15, 25, 35, and 50. So those many people are interested in genetic workshop. So you can switch around to your free workshops, but I wish you should learn this. Thank you very much from my bottom of my not only from Gustavo's heart, also I'm borrowing his heart to thank you everyone. And here now we are going to announce the prizes, and all workshops will be here. Where are going to be there, which is going to be there are going to be some kind of signages there. You can see the signages. Come down. You can announce the prize. Who is going to announce the prize? You can announce the prize. Okay, I'll announce, and Gustavo and all the faculties, you can take up. The first runner-up for the poster prize by Dr. S. Chauhan, large CP rare entity. Is he there? In the paper session afterward. On the paper, there is a tie. We have got 2 runner-ups. One is Dr. Ridhima Tejwani. Dr. Lauren is going to present, and Lauren, wait, you have to wait there for one more runner-up prize, and that is going to Dr. Jyotsna Panigrahi. भाई तू ये काम करना तो मैं ना करूँ पड़े दोस्त आपड़े yeah please.
Wherever I am today, everything my teacher.
No,
Dr.
Your hard work.
That is the only word I want to say. Thank you, everybody. I feel so happy with you all.
So now the poster winner is Dr. Shruti Soman. Mauricio. She had given a talk on spectrum of vascular anomalies, and now the paper winner is Dr. Neha Mahendru, and by Andrea Rigini. Can you stay on that side? So thank you very much. Again, Gustavo, do you want to say something? Because tomorrow everyone is going to be dispersed in a separate hall. So you want to say a valedictory or a last comments to everyone?
Hi, good afternoon. My name is Gustavo Maringer. Nice to meet you. I think that after people took 10,075 pictures of me, it will be very difficult for you to forget me. No joking. I hope and I am sure that you enjoy the conference. I am receiving messages from all around the world, from people that saw the presentations through the Zoom, and many of them are people that I regard highly because they know that they understand, and they wrote me, some of them, that it was the best Congress on fetal brain neurosonography that has been produced with the with the best images, and more important, the most nice guys giving lectures. That is important, not only and thank you very much, Prashant, and your family, and the organizing members, and all the technicians that were here and make almost flawless technical effort that everything went okay. I hope we are going to see you soon in another Congress. It will not be next year. We have decided it will be every 2 years because the changes in the brain are not so fast. But we will be happy if you continue at least connected with us through the media, through the Facebook, internet, whatever, and you will receive the participants will receive our personal emails. So in any moment that you have a question or case interesting, or you think that something you need help, we will be there. And I can assure that usually I answer to 3 to 5 minutes. So don't be shy, and you can send the cases. Thank you again. Thank you again. Thank you again. And safe. Yes. The conference will be ready after for 3 weeks, starting from the beginning of February. So we'll be able to see them, and safe return home. And thank your families for let you be in here, since many of them will remain with the children and do the work at home. And also thank to my wife that is the same.
So I will tell you that how much I would call it as a sacrifice. When a husband is not there, when you have got a 35th anniversary at home, that's what Gustavo Malinger has got his anniversary today, and still he is here, not with his family. There is no more sacrifice any man can possibly think of.
I am going to pay that very, very highly. Mauricio, yes, Mauricio.
No, I have to say that I want to give a special thanks to Prashant. And I want to show you something. What happened before you organize an amazing Congress? Look at this picture. This is before and this is after. This is an amazing Congress. All the best for you. Bye-bye.
Thank you. Thank you very much. Thank you. Yeah, that's correct. There's a change. There is a change within 3 months.
Mauricio is going to send also my picture. Here I look okay. In the picture that he took, I am very, 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 very tall and very slim.
Thank you. See you tomorrow morning, sharp at 9 o'clock. Some of the workshops which will start at 8:30 in the morning. Be on time, because if you must have observed that we are, I would call it very strict with the time. Right. So be present at 8 o'clock or 8:30 in the morning, or 9 o'clock in the ultrasound workshop. Thank you very much. See you again tomorrow morning. There are 5 rooms. There's going to be 1 floor above.